So thank you very much for the invitation. It's a great pleasure to be here. And actually, it's the first time in Luzern for me, and I was really impressed today in the morning when I came and I heard the music. And I was then told it's already the beginning of the Fastnacht. I wasn't aware of that, and I have to say the music is very different compared to the carnival music I know from Cologne or Düsseldorf, for example. So there seems to be a clear difference. So here you see my disclosures. And here's the outline of my presentation. I will give you a short introduction into the topic, and then I will discuss with you different drivers of disease progression, namely inflammation within the CNS, neurodegeneration, and a very short one-slide comment on remyelination, actually. The histopathological hallmark of multiple sclerosis are the focal demyelinated lesions, and here at the bottom you can see, can you see it? Yeah, okay. There at the bottom you can see a typical demyelinated lesion, and you can also see here in the timeline all the drugs that we developed, or that have been developed, to prevent the formation of this focal demyelinated lesion. And this was very successful, so we have a number of compounds that are able to prevent the formation of these lesions. However, this also resulted in the fact that we realize that there's not only disease worsening caused by relapses, but there's also that we now call PIRA, progression independent of relapse activity. And here on the right side, you see that this progression independent of relapse activity is actually responsible for the major part of the confirmed disability accumulation in patients treated with immunomodulatory or anti-inflammatory drugs. So you can see that this accounts for 80 to 90% of the worsening of the patient compared to the relapse-associated worsening. However, currently, I think we are not really able to prevent or treat this PIRA, and this is, I think, partly because we don't understand very well the underlying mechanisms. So current concepts suggest that this progression independent of relapse activity is caused by a combination by non-resolving inflammation within the CNS, neurodegeneration, and the lack or loss of compensatory mechanisms. So here on the slide, on the left side, you see all the different pathomechanisms that we have identified in the past that contribute to the disease course in MS. And what we think that the mechanisms contributing to disease progression are mostly, as I just said, the inflammation in the CNS, in the meninges, in the non-appearing white matter, and in the lesions. In addition to that, we have the diffuse white matter pathology, the injury to oligodendrocytes and the myelin sheath, and we have significant neurodegeneration. We have also in the brain compensatory mechanisms that try to counterbalance these injury mechanisms. This is brain plasticity and remyelination. And to make this whole story more complex is that most likely these different mechanisms vary across patients and even within one patient over time. So if you think conceptually about it, you would assume that a patient who has strong injury mechanisms and weak compensatory mechanisms, these should be the patient with a rapid disease progression. In contrast, patients who have weak injury mechanisms but strong compensatory mechanisms, this should be the patients with slow disease progression, and then of course you have the combination in between. So if we want to tackle disease progression, what we have to do, I think, is either to prevent or to reduce the inflammation within the CNS, and maybe we have the first tools at hand to do so, or we have to promote remyelination and neuroprotection, what I think is actually more difficult. So now I would like to discuss with you these different pathomechanisms. I would like to start with inflammation within the CNS and with the diffuse white matter injury. So before I do that, just brief introduction in the pathology of MS, so just give you that we're all on the same level. So in MS, we have different lesion types. And on the left hand, you see the so-called active lesions. Then in the middle, you see the mixed active-inactive lesions, also called chronic active lesions. And then on the right side, the inactive lesions. The upper panel shows you are staining for the myelin sheath, MVP. So brown shows the myelin, and the white area is the demyelinated lesion. In the lower panel, you see a staining for CD68, which is a marker for myeloid cells, so macrophages and microglia cells. And in active lesion, you see that the lesion is full of these myeloid cells throughout the whole lesion area. And then over time, you have a resolution of inflammation, and either the inflammation persists in a rim at the lesion border, then you have the chronic active or mixed active-inactive lesions, or you have a complete resolution of inflammation, and then you end up with an inactive lesion. So what is important to understand is that actually these lesions are not static. It's a dynamic process. It starts with an active lesion, then over time you have a lesion of inflammation, and then if it goes very well, you have an inactive lesion in the end. So in recent years, there was a special focus on these chronic active or mixed active-inactive lesions. And this is because now it becomes more and more clear that at least a subset of these lesions are associated with a worse disease course. So on the left side, again, you see a staining for a myeloid marker, HLA-DR, and you see again, I think very nicely, this rim of myeloid cells at the lesion border. In a small subset of these chronic active lesions, they account for approximately 30% of all lesions in MS autopsies. So this we know from a large autopsy study done in the Netherlands, from the Netherlands Brain Bank, where they analyzed the lesions from almost 200 brain donors. And there, the mixed active and inactive lesions accounted approximately for 30% of all lesions. In a subset of lesions, you can find iron deposit in the microglia cells at the lesion border. However, this is only a small subset. So I analyzed in our institute some of these mixed active inactive lesions, and there I found only in approximately 20% of these mixed active inactive lesions significant iron accumulation in myeloid cells at the lesion border. So it's only a small subset. And these mixed active-inactive lesions with iron deposits can be visualized by MRI as paramagnetic rim lesions, pearls, and I'm pretty sure that Christina will speak about them in the next presentation. And one small detail I would like to mention, because it's not so prominent in the whole discussion, is that you can find these myeloid cells with iron deposits also in active lesions, but the distribution is very different. You find them actually perivascular. And this is, I think it's a very interesting finding. And I guess so far we don't really understand what these iron deposits actually mean in the myeloid cells. And it's a cause, consequence, or whatever. What does it indicate? So I think we have to do a little more to understand that. So these mixed active-inactive lesions, they are, and we know from imaging that these pearls, at least, if you have a higher number of pearls, it's clear that you have a worse, or this is associated with a worse disease course. So the question occurs, is it only a biomarker, or is there also underlying molecular or cellular reasons why these lesions are bad for MS patients? And at least there are some things that are associated with these mixed lesions that I think that are negative for patients. So on the one hand, if you have this rim of myeloid cells, that means that you have continuous acute axonal injury shown on the left side. So these little black dots on the APP staining are all transected axons. And axons that are transected in the brain, they won't recover, so they are lost forever. So and then in the middle you see that is also that this rim of myeloid cells is also associated with a strong oligodendroglial loss. So on the lower panel in the middle, you see the quantification of oligodendrocytes in different areas in the non-appearing white matter, in the periplaque white matter, that means directly adjacent to the MS lesion, then at the border where you have the rim of myeloid cells, and then in the lesion center. And you can see that there's a significant drop of oligodendrocytes exactly where you have all these myeloid cells. And if you look for remyelination, what is also very obvious, remyelination is almost completely lacking from these mixed active-inactive lesions. So indicating that this environment that you have at the lesion border is really negative for oligodendrocytes and for remyelination, and also detrimental for axons. Then during the last years in a project, what we realized that actually this myeloid rim is not always the same. So what you can find actually, it's very different sizes of the rim of the myeloid cells. And on this picture on the right side, you see the classical mixed active-inactive lesions, and there the thickness of this myeloid rim is approximately 300 micrometers. However, we realized that there are also patients who have a very broad rim of these myeloid cells. It's what you can see on the left side. And we termed these lesions broad rim lesions. And you can see on the left side a hypocellular lesion center. And then you see indicated by the dashed white lines this rim, this very broad rim of myeloid cells. It's more than 1 millimeter. And we found these broad rim lesions, especially in patients with a very rapid disease progression. So what we did, we collaborated with the colleagues in the Netherlands Brain Bank, and two very experienced neurologists, Louisa Klotz from Münster and Jo Smolders from Amsterdam. They went through all the medical records of the patients in the Netherlands Brain Bank. And then they stratified the patients for extreme clinical phenotypes either with a very slow disease progression or very rapid disease progression. And they tried to exclude patients where the disease progression was caused by relapses. And what they found were, on the one hand, these patients indicated in blue. These are patients with a slow disease progression, so the disease starts around 30 years of age, and they passed away around the age after approximately 40 to 45 years. On the other hand, you had the patient with a very rapid disease progression. Again, the disease starts around 30 years of age. However, these patients died on average after 15 years of the disease duration, so really an extreme phenotype of the patients. And in 11 out of 70 patients with this very rapid disease course, we could find these prodrome lesions, but only in 1 out of 26 patients with a very slow disease progression. So indicating that this is indeed a marker for rapid disease progression. We then went back to the whole brain donor cohort of the Netherlands Brain Bank and looked whether we can find more patients who have these prodrome lesions. And indeed, we found these prodrome lesions in approximately 23% of all brain donors in the Netherlands Brain Bank. And if we then again looked for the clinical details, we could see that patients who had these prodrome lesions had a significantly faster disease course, and they also had a more severe disease course. And in a follow-up project, Lucas Lietje, a PhD student at the Netherlands Brain Bank, he then did a, I think, very tedious task where he analyzed the thickness of the lesions rim in a large number of patients to be able to do a correlation between the thickness of the rim and the disease course. And again, as you can show that here, there's again a correlation between the severity of the disease course and the broadness of the rim. So indicating that indeed this broadness of the rim is somehow a biomarker for a more severe disease course. And we also teamed up with colleagues in Finland, Laura Ayres and her team, and they were able to identify the radiological BRLs using TSPO PET. And also in their patients cohort, they could demonstrate that patients who had these radiological BRLs had a worse disease course. So then, of course, the question occurs, first of all, why is it only a biomarker or is it causal? Okay, so for that, we don't really have an answer. But the other question that occurs is, what are the mechanisms that result in the formation of this rim? And there's a nice study from Martina Absinter and Dani Reich, where they did single nuclear sequencing and they analyzed the cellular composition in classical mixed active inactive lesions. And there they found what they call the interactome, so an interaction between the myeloid cells and lymphocytes, which most likely is through reciprocal interaction lead in the perpetuation of this rim. We did a similar analysis. We did spatial transcriptomics, and we analyzed the signatures, the transcriptomic signatures of myeloid cells, either in the rim of prodrome lesions, in the rim of classical mixed lesions, or in active lesions. First of all, what you can see, the transcriptomic profiles of the myeloid cells in these 3 different lesion types are different. Yeah, so you can find differences. And you can also find what we call a shared signature between all 3 lesion types. And this shared signature, what you can find there is, on the one hand, this is not surprising, GO terms related to antigen processing and innate immunity. But you could also find GO terms related to adaptive immune response and the activation of B and T cells, further supporting the notion that you have the interaction of lymphocytes and myeloid cells that is responsible for the perpetuation of inflammation. We also find GO terms that were specific for the BRLs, and they were related to pro-inflammatory cytokine production, enhanced protein turnover, and myeloid cell migration. And we interpreted that in a way that this suggests that enhanced myeloid cell activity is present in the BRLs due to ER stress and unfolded protein response. Another very interesting detail, I think, that Laura Ayres and her team observed, they had a small cohort of patients. Some of them were treated with natalizumab and some not. So it's only 9 versus 9, and they had the chance to do a follow-up over time. And what they could observe in this patient cohort, that patients were treated with natalizumab, they observed a disappearance of the BRLs, and in patients not treated, they persisted. And this, for me, raised a very interesting question. Does it mean that we still have a low-level influx of lymphocyte into the CNS, and that this is maybe a driver of these prodrome lesions? What then would question our concept of the compartmentalized inflammation behind a closed blood-brain barrier? I think that's a very interesting question and observation that deserves further studies. Okay, so now I come to the diffuse inflammation in the so-called normal appearing white matter, and this is mostly microglia cells. So if you look on the left side in the upper panel, you see a stain again for a myeloid marker in an MS tissue sample, and below you see a staining for a control. And I think by eye you can already see a difference. We quantified it, you see the quantification, indeed you have a higher number of HLA-DR positive myelocyte in the normal appearing non-demyelinated white matter of MS patients. And you can make similar observation again if you use TSPO PET. Also there you find a higher TSPO PET signal in the normal appearing white matter of MS patients. And you find again a higher number or higher TSPO PET signal in patients with a progressive MS compared to patients without the progression. And another interesting observation, it's only one case, it's only a case report, but what this patient was treated with rituximab, and again, TSPO PET was done before and after treatment, and the red color shows you the healthy controls as comparison. The green column shows you before treatment, and the blue columns after treatment. And again, you can see that after the treatment, at least very obvious for the thalamus, there's a significant decrease in the TSPO PET signal, again raising the question, was it a connection between the peripheral immune system and the microglia activation in the CNS? So then the next question is, does it matter if you have a microglia activation in the normal appearing white matter? And the answer is yes, at least you can find pathological changes. So this again is a study from the Amsterdam group. And here you see on the left side again the microglia activation in the normal appearing white matter. What they also observed in these tissue samples was subtle changes in the paranodes. The paranodes is a structure for the myelin sheath. It's important for the organization of the nodal structures and the generation of action potentials. And if you look on the Caspar staining at the top, you can see that the paranode structure is actually longer in MS patients compared to controls. And this then results in a disorganization of the paranode structure, as you can see it in these little diagrams below. What you can also find in these patients are increased numbers of mitochondria in the axons in the normal appearing white matter. And this normally indicates that the axons have a higher energy demand. And this is mostly caused, at least in other scenarios, due to axonal injuries like demyelination and maybe also subtle paranodal changes. And if you do mathematical modeling and you ask the question, okay, do these subtle changes of paranodes, do they matter? At least in the mathematical modeling, they could show that even slight changes at the paranodes can result in the delay in the velocity of action potentials. And if you have this throughout the whole brain, of course, one is wondering, what does it mean for a patient? So now I come to a new generation and very short, briefly to remyelination. So this slide is just to remind you, if we speak about neurodegeneration, mostly we speak, as I will do, about loss of neurons and synapses. But of course, neurodegeneration is clearly more complex than that. You have also, already demyelination is part of neurodegeneration. An axon was myelinated, it's not supposed to demyelinate it. If the axon loses the myelin, it's an injury to the axon, actually. And then all the other mechanisms that I mentioned here that I can't talk about today. So this is a very nice study from Christina. Maybe we'll talk about that as well. Yeah, it's just to show you that patients who have PIRA, that they have significant cortical atrophy, and this is even larger than in patients with relapses. And then the question occurs, okay, what are the underlying molecular and cellular reasons for this cortical atrophy? And of course, one reason for that is neuronal loss. And there's a very nice study, this was published already almost 20 years ago from the colleagues in London, where they correlated the extent of neuronal loss in the cortex with the extent of meningeal inflammation. So what you see at the bottom, I think that you get three important messages from this little diagram. So what you see on the x-axis with 1, 2, 3, 4, 5, 6 are the cortical layers. So 1 means close to the CSF, 6 means directly to the white matter. Then on the y-axis, you see the reduction or the loss of neurons. The black lines are patients with significant meningeal inflammation. The gray lines are patients without the significant inflammation in the meninges. And what you can see is, first of all, that patients who have significant inflammation, they have a clearly higher neuronal loss. The second thing you can see that the loss is most prominent close to the CSF. And the third thing is they differentiated between the cortical lesions and the non-demyelinated gray matter. And the neuronal loss is slightly higher in the cortical lesions, but however, it's also very significant in the non-demyelinated gray matter, indicating for me that this loss is actually caused by soluble factors released from the inflammatory cells in the meninges. The same group did a very similar study where they looked at the thalamus, so close to the ventricular system, and they found exactly the same. Again, the closer to the CSF, the higher the loss of neurons. Patients with significant inflammation in the meninges had a higher loss, and you could also find a significant loss of neurons in the non-demyelinated thalamus. So exactly the same finding at the cortex, further supporting that the inflammation in the meninges is responsible for neuronal loss close to the CSF. However, we don't have only the neurons, we also have the synapses. And most likely before the neuron is lost, there will be a significant loss of synapses in these neurons. And the first study which has shown that is a very nice study from Doron Merkler, now in Geneva, where they quantified the synapses in cortex of MS patients, in lesions and outside of lesions. And you see these little circles, they all indicate spines, and on these spines are the synapses. And I think it's very obvious from the pictures that you have a significant loss of the spines in the lesion and also in the non-demyelinated cortex. And below, again, you see the quantification. And it's the same phenomenon we saw with the neurons. This loss of synapses is not limited to the lesions. You find it also outside of the lesions. Nowadays, we have a chance to measure that in patients, what I think is very exciting because it will help us to understand what actually that means if we lose synapses and how much it contributes to the disease progression in patients. So this is a study, again, from Laura Ira's group, where they used a PET tracer to detect synapses. And in yellow, you see the MS patients, and white the controls. And they analyzed the PET signal in different cortical areas. And in all the cortical areas, you see a clear decrease in MS patients compared to healthy controls. And what they also found that this synaptic density very nicely correlated with the performance in cognitive tests. And they also looked at patients where they had a change, where they had a longitudinal analysis of the cognitive performance, and patients who had the worst, the strongest decrease in cognitive performance, they had the lowest PET synaptic levels. A similar study was done from Martin Kerschensteiner and his group in Munich, where they also used this tracer, and they also looked for the synaptic density in the cortex of MS patients. And I try again whether you can see anything. Yeah. Okay, so what you can see here is the measurement of the PET signal either in the lesion compared to the normal appearing gray matter, and you can see there's a slight decrease in the lesion. And then they used this PET signal and they translated it in something that they call the cortical parameter of cortical pathology. And they could show that MS patients had a higher level of cortical pathology compared to patients with epilepsy. This is the control cohort. And they could show that actually this PET imaging was much more sensitive to detect cortical pathology than classical MRI, where you can detect the cortical lesions. So it was 20 times more sensitive in detecting cortical pathology than classical MRI. They also found that there was a higher cortical pathology in patients with progressive MS compared to patients with relapsing MS. Interestingly, they didn't find a correlation with age or disease duration. They also then correlated these PET signals, the cortical pathology with the EDSS score and found a very nice correlation. And they found an inverse correlation, again, with cognitive function. So I think this is also very nice data, and I think it will help us to understand, I think so, when actually these neurodegenerative mechanisms start, and maybe whether there are certain subgroup of patients where this synaptic loss is already very prominent very early during the disease course, and maybe could explain why some patients start already very, very early with this theorem. Yeah, and I think the task for all the researchers among us for the next years will be to understand the cellular molecular mechanisms driving these neurodegeneration in MS patients. And I think that mechanisms, tools like spatial transcriptomics will be very instrumental in understanding these mechanisms. And with that, I come to my actually almost last slide. This is about remyelination. So after all these injury mechanisms, I will end with a hopeful note, actually. So remyelination occurs, and it's especially prominent actually in the cortex. Again, there was a recent PET study where they also looked for remyelination in the cortex, and interestingly, what they observed was that remyelination in the cortex was more extensive in the lower cortical layers compared to the upper cortical layers, again indicating that the inflammation of meninges is also detrimental for remyelination. We know that already from periventricular lesions, which don't like to remyelinate. And what they could also show that actually the patients who had a higher extent of cortical remyelination, they had less cortical atrophy. However, only in a subgroup of patients this was associated with a lower probability of disease progression. And only in patients who had a short disease duration of less than 5 years and limited demyelination of the cortex, they could find this positive or this beneficial correlation, potentially indicating that remyelination, yes, indeed is able to compensate for some injury, but maybe only for mild injury. And with that, I come to the summary of my presentation. So I showed you that the MS disease course should be considered as a disease continuum driven by different pathophysiologies, and these pathophysiologies vary across individuals and over time. Non-resolving inflammation in lesions, non-moving white matter, and meninges associated with oligodendroglial, neuronal, and synaptic pathology. Broad myeloid cell rims around focal lesions, BRLs, are a biomarker for rapid disease progression, and the broadness of the myeloid cell rims may indicate the activity of the immune response. Many underlying mechanisms are closely interrelated, so I think inflammation is at the beginning of everything, in my opinion. However, the tools to identify and measure specific pattern mechanisms, for example, synaptic pathology, are continuously improving. And of course, as always, there are many open questions, and I will here state the 3 that I currently find the most interesting one. So why do myeloid cell rims persist in a subgroup of lesions? Is it caused by qualitative or quantitative difference in the innate or adaptive immune system, or due to specific interaction between the 2 immune systems? Is the inflammation independent neurodegeneration? So I think at the beginning it's all caused by inflammation. However, the question is whether we have later during the disease course an uncoupling of inflammation and neurodegeneration, and maybe there are some mechanisms triggered that even if we then stop the inflammation, will continue. And the last question, which maybe is the easiest to answer in the near future, how efficient is remyelination in preventing disease progression? And this is the last slide. I would like to thank my fantastic team in Münster and all my great collaborators around the world, and you for your attention.